Hello everyone, and welcome to today's lecture on the upper limb, specifically the pectoral and axillary regions. We're going to start with objectives as always, and so we'll go through these each in their own turn and use these to organize the way you review this material. First objective, we're going to talk about the breast tissue first. We're going to start from superficial to deep in the pectoral region, and as the breast tissue is part of the superficial fascia, we'll cover it first. So, the anatomy of the breast includes adipose tissue and glandular tissue. And the adipose tissue and glandular tissue are sort of mixed together and separated by a little bit of a connective tissue fascia into these lobes and lobules, as you see in the image here. The breast occupies a space called the bed of the breast, which lies superficial to the pectoral muscles. It is found medial to the axillary region and lateral to the sternum. And so you can review the specific details here. I do also want to point out in terms of compartments, I mentioned the connective tissue. So this divides the breast into these various compartments using connective tissue fascia. Where that fascia is a little bit thickened and attached to the skin, it creates suspensory ligaments. The glandular tissue is divided up into various lobes and lobules, each of which drains into a lactiferous duct. And at the distal end of the lactiferous duct is a small enlargement called the lactiferous sinus, which is found immediately deep to the nipple. Here we see a breast in cross-section, and we can see how each of these little spaces here is part of the lactiferous duct. So, a lactiferous duct for each lobule, and those ducts all lead towards the nipple. Each duct has its own opening, and then this tiny enlargement here is the lactiferous sinus. Notice also the other relationships here. All of the breast tissue is within the superficial fascia, so the fat and glandular tissue lies superficial to the pectoralis major muscle. In the small inset image, you see here the organization of the lobules. Each of these is a secretory unit which drains into a duct, and then those ducts coalesce into the larger lactiferous duct, which should actually be visible in dissection. Lymphatic drainage of the breast is pretty important because of spread of cancer, and so we don't often emphasize lymphatics in this course, but there are a few places we want to point out some things. So basically the idea here is that all lymphatics from the breast drain into the axillary nodes eventually. Okay, so if you follow these red lines, you can see lymphatic drainage all leads towards this chain of axillary lymph nodes, and from there towards the main lymphatic duct. And so if you're on the right side, it'll drain through the right lymphatic duct. On the left side, it drains through a structure called the thoracic duct, but the drainage is largely symmetrical. The other important thing to notice here is that the medial quadrants of the breast will drain towards these sternal lymph nodes or parasternal lymph nodes, and those can actually cross the midline. So oftentimes we think of lymphatic drainage as being isolated to one side of the body or the other, but there are a few cases where you can have lymphatic drainage crossing the midline. So you could actually end up with a cancer spreading from left side to right side or vice versa. And so I've already mentioned a little bit about spread of cancer, and so I just want to point out that this is one of our sort of clinical questions if you think about cancer cells spreading through lymphatic drainage. All of the axillary lymph nodes can be divided up into these categories here. I don't think you need to memorize these in any great detail, but just recognize these names are all subcategories of the axillary lymph node chain. We're now going to move on to the musculature of the pectoral region, and then we'll talk about the innervation and blood supply to the muscles of the pectoral region before we move on to the axilla. The pectoral region contains basically two large muscles. There is the pectoralis major, which we see here, and the pectoralis minor we'll see in a moment. The pectoralis major has two origins. It has a clavicular head, which originates on the clavicle, and a sternal head, which originates along the sternum and even down to the costal cartilages. All parts of the sternum insert onto the humerus, specifically the lateral lip of the intertubercular groove. So as you review the osteology of the upper limb, make sure to pay attention to the intertubercular groove on the humerus, because a lot of muscles have important attachment sites there. And so this knowing these two attachment sites can help us to infer the action. So basically when these muscle fibers shorten, they're going to bring the humerus closer to the sternum, and so that means adduction. All right. because the muscle is attaching to the anterior surface of the humerus. It also acts as an internal or medial rotator, and it also acts as a shoulder flexor. All right, so this is bringing your upper limb forward. All right, so think about if your arms are at your side, think about raising your arms straight up, like I don't know how, like a Frankenstein walks or something, with arms straight out. That would be arm flexion. The pectoralis major can also act as an accessory muscle of inspiration, so that is breathing. So if the shoulder is fixed, if you're not moving your humerus and you're taking a deep breath, pectoralis major assists in moving the ribs for breathing. Innervation of the pectoralis major comes from the two pectoral nerves. Those pectoral nerves are called medial and lateral, and we'll see their exact paths here in just a moment. Pectoralis minor is still a relatively large muscle, but it's smaller than the major. It's found immediately deep to pectoralis major, and it's going to originate on ribs 3, 4, and 5, so it has 3 rib attachments, and it inserts up here the coracoid process of the scapula. We often define coracoid process of the scapula as the insertion because that's usually the moving point when you're using pectoralis minor to move the upper limb. It helps to rotate the scapula to allow you to to flex your upper limb forward. It can also assist in depression of the scapula. So if you're like reaching your arm down, you have to lower the scapula a little bit to give more mobility to the upper limb. Similarly to how the pectoralis major works, we have another action here. It can also act as a muscle of inspiration. So if you're holding your shoulders stable and taking a deep breath, this muscle will also pull on the ribs to allow you to take a deeper breath. The pectoralis minor is innervated by only the medial pectoral nerve. So the pectoralis major muscle gets both pectoral nerves, but the minor only gets the medial. Here we see those pectoral nerves in detail. We can see how the medial and lateral pectoral nerves are named. Okay, so the medial pectoral nerve has a more medial course, and the lateral has a more lateral course. Now, ideally, usually that's what we'll see. Sometimes, however, they can appear opposite of that, and that's because their names actually come from their origin on the brachial plexus. So the brachial plexus is probably like the main point of today's lecture. We're going to spend a lot of time on that. But the brachial plexus has these two large bundles of nerves called the lateral and medial cords. And so the lateral cord arises from these higher spinal levels and travels down the upper limb laterally, if we were to trace it this way. The medial cord originates from lower spinal levels, and if we follow it down, it ends up on the medial side of the upper limb. So the pectoral nerves are named for the cord from which they arise. So lateral pectoral nerve from the lateral cord, medial pectoral nerve from the medial cord, regardless of how they're positioned. So as these nerves down here, as we dissect these nerves in the pectoral region, they might not appear to be in the medial lateral position. But if we trace them back to the cord from which they arise, their names will make sense. And so just to kind of remind you this thing we referenced on the earlier slide, the lateral pectoral nerve innervates the pectoralis major only. The sort of mnemonic for this is the lateral pectoral nerve does less. All right, lateral less. It only does one muscle. Whereas the medial pectoral nerve innervates both pectoralis muscles. The medial does more, and the medial is also the only innervation of pectoralis minor. Medial does this by piercing through the pectoralis minor. So as you're dissecting pec minor, you should see a nerve passing straight through both of its surfaces, and that's another way we can identify the medial pectoral nerve. The other muscle of the pectoral region is not named pectoral, it's instead called serratus anterior. And so you may remember from our back dissection, we had a serratus posterior superior and a serratus posterior inferior. All of these serratus muscles are named because they attach to various structures in this zigzagging pattern, looking like the serrated edge of a knife. So the serratus anterior is largely unrelated to the other serratus muscles, they just have similar names. And so this one is called anterior, of course, because it comes around to the front side of the body. It originates on ribs 1 through 9, and so it'll be found deep to the pectoral muscles. The lower fibers of serratus anterior here on ribs 6 through 9, something like that, those will all be visible superficially. They are not covered by a pectoralis muscle. So if you see somebody with like really well-developed musculature, it looks like you can kind of see their ribs sticking out on the side. It's actually the serratus anterior that's visible because it lies on top of the ribs. And so this is sometimes called the boxer's muscle because the main action of this is bringing the scapula forward, protracting the scapula. And so if you think about pushing your arm out forward as far as you can, you're going to have to use serratus anterior to adjust the scapular position so you can reach your arm forward, as in throwing a punch. The innervation of this muscle is through the long thoracic nerve, and that's another one we're going to look at in detail because it has a kind of a special course. Here we see the long thoracic nerve. So the long thoracic nerve originates way high up in the cervical region. So it comes from C5 through C7, so the upper part of the brachial plexus. It travels onto the serratus anterior superficially. Notice here, it's on the superficial surface of the muscle. This is somewhat uncommon. Nerves usually enter muscles from the deep surface, so they have a little bit more protection. But the long thoracic nerve being on the superficial surface of the serratus muscle means it is really only protected by the superficial fascia of the trunk. And so if you have an injury to the side of the thorax, this nerve is pretty easily injured because there's not much covering it. Really, most of its protection comes from the upper limb. If you imagine how your arm sort of hangs at your side, that's basically the main protection of this nerve. And so, yeah, what is protecting the long thoracic nerve? Not much, all right? So, yeah, if something does manage to hit the side of the thorax, this nerve can be easily injured. All right, next we're going to move into the axilla. All right, so we're going to talk about this armpit region, and this is where things are going to start to get a little bit more challenging, and especially as we talk about the nerves. So if you've been, sort of paying just a little bit of attention, I'd recommend tuning back in for this portion. So the axilla is defined as this pyramidal space deep to the axillary fossa. The axillary fossa is the superficial or surface anatomy that we see right here. So the axillary fossa is the armpit colloquially. So the axilla, more specifically, is a three-dimensional area deep to the skin of the armpit. We can define the boundaries of the axilla on surface anatomy here with these folds. So there's an anterior axillary fold, which lines up with the pectoralis major muscle. There's a posterior axillary fold, which lines up with the latissimus dorsi muscle. And then between those, the midline of the axilla here is the mid-axillary line. And that basically defines the most lateral part of the body. Once you cross that line, you'll be either on the anterior or posterior sides. And then the other sort of structure or visible thing in the surface anatomy here, we see the end of the serratus anterior muscle. So as I described earlier, how it lies on top of the ribs, it looks kind of like ribs, but if you have well-developed musculature, you can actually see that muscle there on the surface anatomy of the axilla. This smaller picture here, we see basically the shape of the axilla in 2 dimensions is sort of a triangle. So in 3 dimensions, it is a pyramid, and we're going to look at that as well. So here we're trying to give sort of that 3-dimensional view of the axilla. So the axilla is this 3-dimensional space that is filled with lots and lots of stuff. Just real quick, kind of the conceptual idea of the axilla is it is the main pathway for structures to enter the upper limb. So any innervation or blood supply, lymphatic drainage, anything traveling into the upper limb has to do so through the axilla. So the axilla effectively connects the thorax to the upper limb. It also connects the neck and thorax and allows the neck to connect to the upper limb through this superior opening, the apex of the axilla, which is sort of a space which communicates into the neck called the cervico-axillary canal. And so that name makes sense, right? Cervical means neck, and so this is the pathway from the cervical region into the axilla. The base of the axilla here is defined by the skin of the axillary fossa. All right, so the skin of the armpit is what defines the base of the axilla. The anterior wall of the axilla, as we can see right here, this sort of triangular face, this is going to be defined by the skin of the pectoral region and the pectoralis major muscle. Here, let's look at the axilla from another view and keep defining its borders. All right, so we're looking into the axilla with a sagittal section with the upper limb removed. And so All of this space here outlined in these black lines is the axilla, and you see how much fat is there and how much important, neurovasculature and lymphatics we find in that space, okay? So the anterior boundary of the axilla is the pectoral muscles. The posterior boundary is the subscapularis muscle, which is the muscle between the scapula and the ribs. Excuse me. And then the posterior inferior boundary is latissimus dorsi, which you'll recall is what makes that posterior axillary fold when seen in surface anatomy. The deep surface or medial surface of the axilla is formed by the serratus anterior, where it lies atop the ribs, and the lateral boundary of the axilla is formed by the humerus. All right, so this is the space between the ribs, the humerus, the scapula, and the pectoral muscles. All right, so definitely take some time looking at these images to make sure you can kind of orient yourself in this space. So you understand what are the boundaries of the space, because if you kind of know where you are, tracing what passes through the axilla becomes much easier. And again, that's going to be kind of the main point. So let's go ahead and start talking about the axillary contents. All right, I've referenced it has lots and lots of important stuff. All of the structures that travel to the upper limb have to get there by passing through the axilla. And so that will include the axillary artery and vein, which are, real big vessels that provide all the blood to the upper limb. This is also where we find the axillary lymph nodes, which are, we talked about earlier where like breast cancer drainage would happen. So the axillary lymph nodes are found within the axilla. And then of course this whole thing is surrounded and protected by fat. If you notice from the previous images, the axilla does have pretty good, bony protection, but you have a lot of fat in there to provide flexibility and sort of additional protection. You can't put too much bone in this region because then you're going to lose the mobility of the upper limb. So this fat is necessary as protection, but also a compromise with flexibility of the shoulder joint. Oh, and I should definitely talk about this. The brachial plexus. So the brachial plexus is this big complicated bundle of nerves that supplies all the innervation to the upper limb. All the sensory and motor innervation of the upper limb passes through the brachial plexus, and the brachial plexus is found inside the axilla. And so we see here three sort of parts of the brachial plexus. I also want to point out how those individual nerve cords are directly surrounding the axillary artery. So as you're dissecting this, you're going to want to be careful separating the nerves from the artery and making sure we can tell which is which. Let's pause for a question. All right, I'm not going to give you any context here. I'm going to just ask you to take a look at the image and see if you can figure out what this nerve is. All right, I'll give you a moment to pause and think if you wish. And we're back. All right, so this nerve we're seeing here is coming off of this more posteriorly oriented nerve cord, which as you learn more about the nerves of the axilla, you'll recognize that as the medial cord of the brachial plexus. All right, so that's one clue. And then we see how this nerve is coming through here. It's actually piercing through the pectoralis minor muscle and then passing directly into the pectoralis major muscle. So I would say this nerve is innervating more muscles. It's innervating two muscles. It's coming off of the medial cord, so this must be the medial pectoral nerve. And so here's the explanation for that. All right, on to the axillary artery. So we're going to trace the axillary artery through the axilla and discuss some of its branches. So the axillary artery is a continuation of the subclavian artery. The subclavian artery is a huge artery that comes out of the thorax, passes deep to the clavicle, as the name implies, and then it continues on to actually supply all the blood to the upper limb. So the subclavian artery changes names to become the axillary artery right as we cross the border of the first rib. If you can't find the border of the first rib, the clavicle is pretty close. So where the subclavian artery passes deep to the clavicle after it comes out from behind the clavicle, it's become axillary. All right. The axillary artery ends down here where it crosses the border of the teres major muscle. At that point, the axillary artery becomes the brachial artery. All right, so this is just like a street that changes names as you're driving down it. The subclavian artery becomes the axillary, and the axillary becomes the brachial. The brachial continues through the upper limb and supplies all the structures in the upper limb itself. So the axillary artery is the supply of the brachial artery, And the axillary artery also gives off many branches in the axilla itself to supply the pectoral muscles, the shoulder joint, things like that. The other sort of note here is that if you can't find the teres major muscle, if you can find the edge of latissimus dorsi, that's close enough, all right? So the official begin and end of the axillary artery are mentioned, but I've also included little notes here of things that are maybe easier to spot that are pretty close to accurate, so you can use those if they're easier to see. The axillary artery can be divided into three parts. These parts aren't necessarily like anatomically different. This is just a way of categorizing the branches that can help you when you're observing this. And so the three parts of axillary are defined by the location of the pectoralis minor muscle. If you are medial to the pectoralis minor muscle, we call that the first part. If you're lateral to the pectoralis minor muscle, we call that the third part. And if you're deep to the pectoralis minor muscle, if you're in the axillary artery that's covered by the pec minor, that is called the second part. All right. So if you can find how pec minor crosses the artery, you can define the three parts. And we can then talk about the branches off of each of those parts. So in this view, we have added in all of the branches from the three parts of the axillary artery. And so there's a little bit of a useful mnemonic here, is that the first part has one branch, the second part has two branches, and the third part has three branches. So if you can kind of keep in mind that 1, 2, 3 pattern, it makes this a little bit easier. So let's go ahead and start naming those branches. The one branch off of the first part is called the superior thoracic artery. This comes down to innervate the muscles between the ribs, the first couple of intercostal muscles, and that's it. The second part, excuse me, the second part of the axillary artery has two branches. It has a thoracoacromial trunk, which we'll mention in a moment, and it has the lateral thoracic artery. This lateral thoracic artery travels down the thoracic wall to supply blood to the serratus anterior muscle. So the serratus anterior, we already saw its innervation was from the long thoracic nerve. Here we see its blood supplies from the lateral thoracic artery. The third part of the axillary artery has three branches. It has one branch called the subscapular artery, and then it has these two humeral circumflex arteries. So much like in the femur, we had circumflex arteries wrapping around the neck of the femur to supply the bone and the joint tissue. Here we have humeral circumflex arteries, which do much the same. But pay attention to the naming. They're in this case called anterior and posterior humeral circumflexes, as opposed to medial and lateral, like we saw in the femur. All right, so let's go back and talk about some of these branches that have specific branches of their own. Let's go back and cover this thoracoacromial trunk. The thoracoacromial trunk has four branches. The thoracoacromial trunk supplies all the regions, including the thorax and acromion. All right, so the name tells you kind of where it's going. And so the acromion is part of the shoulder, and the thorax is the thorax. And so the branches here, I remember them as A, B, C, D. All right, they're in alphabetical order. A is the acromial branch, which goes up to the shoulder joint in the acromion. B is for breast, and it's actually called the pectoral artery, but if it helps you remember, the clavicular branch goes straight up to the clavicle and supplies some of the muscles there, and then the deltoid branch travels out directly laterally to go into the deltoid muscle. All right, so the thoracoacromial trunk itself is very short because it almost immediately branches into these four other branches. These four other branches will be defined by the direction they travel. So when you're identifying these, you want to make sure that you can see which direction they're headed. Okay. Moving on now to the other branches of branches, we'll talk about the subscapular artery. So the subscapular artery branches off of the third part of the axillary artery and travels down along the anterior surface of the scapula, and it has two branches of its own. One of these passes around posteriorly, passes behind the scapula, is called the circumflex scapular artery. It's going to supply the muscles on the posterior side of the scapula, and then the continuation of this is the thoracodorsal artery, which is going to end up in the latissimus dorsi as its main blood supply. All right, let's briefly talk about veins. So veins always follow arteries, right? So like all those arteries I just mentioned on the previous slide, they all have corresponding veins. And we're not necessarily going to spend a lot of time on those veins, all right, because they're deep veins and they have a corresponding artery. But here, I want to talk about some of these superficial veins. So much like the saphenous veins of the lower limb, how they travel in the fat and skin, you have superficial veins in the upper limb. And so the superficial veins in the upper limb are called the cephalic and the basilic. The cephalic vein travels up the lateral side of the upper limb, passes over the deltoid, and ends up connecting into the axillary vein. The basilic vein travels up the medial side of the upper limb, and it effectively becomes the axillary vein. All right, so the basilic vein is effectively the main drainage into the axillary vein. There are also brachial veins, which are deep in the upper limb and correspond with a brachial artery. So the axillary vein has three main tributaries, all right, three main sources that it's draining blood from: the cephalic vein, the basilic vein, and the brachial veins. The cephalic and basilic are specifically important in upper limb anatomy because they are visible in the superficial fascia. They can be used for blood draw. All right, so when we talk about the elbow specifically, we'll kind of revisit this concept. I want to just remind you that veins are variable. They have lots of different branching patterns, and so what we see here is just one possibility. But the sort of textbook example is there's one cephalic vein and one basilic vein. Here we see how the cephalic vein travels very superficially along the lateral surface of the upper limb and passes between the deltoid and pectoral muscles in a space called the deltopectoral groove. Now, the cephalic vein, as we see in this individual with well-developed musculature and low body fat, cephalic vein is very visible superficially, and relatively large because it's draining a lot of territory. In a lot of our donors, the cephalic vein will tend to be very small, and so this is just natural variation, also combined with lifestyle stuff. If you're using upper limb musculature a lot, you're going to need more blood supply, which means you need more more venous drainage, and so this vein will grow larger. All right, so the cephalic vein is pretty easily visible. The basilic vein by this point is sort of hidden under the upper limb, and it's already starting to travel more deeply in that point. And so just to remind you, upper limb venous variations, all right? The deep arteries, all right? All of the arteries we've talked about have a vein running with them. Venous distributions are highly variable, and that's why we don't usually spend a lot of time dissecting them, but the cephalic and basilic veins in the superficial fascia are pretty important, so we want to make sure we can follow those patterns. Ah, yes. So, just an illustration of venous variation. If you look at Chris Hemsworth's arm, all right, I mean, I know this is something we all want to do. Take a look at the branching of his cephalic vein. It actually has this additional branch here, which is atypical, all right? So let's zoom in on that. You see there, it has this extra branch, all right, that, you're not supposed to have. So next time I hear somebody talking about how perfect Chris Hemsworth is, he's got weird veins, all right? So yeah, that's just a fun example. Like I can't watch a Thor movie without looking for his arm veins. So, all right. Now into the hard part. All right. I know we've already covered a lot of material, but this is where you're probably going to want to focus your time because the brachial plexus is challenging for a lot of people, but you really need to understand how each of these nerves is formed and how they travel so we can understand the innervation of the upper limb. All right. And so the brachial plexus is all of the stuff that we see here. All right. All of these nerves. And so these nerves originate from the nerve roots C5, C6, C7, C8, and T1. Okay, so we have these 5 spinal levels which are contributing into the brachial plexus. All right, and so each of these spinal levels has a spinal nerve, and that spinal nerve has a dorsal and a ventral ramus, as you'll recall. And so the ventral ramus, all of the ventral rami sort of come together as these roots. All right. Now, unfortunately, this word root is used twice. We have spinal nerve roots, but when we say root of the brachial plexus, we're actually talking about the ventral rami. All right. I'll give you a moment to let that sink in. When we talk about the roots of the brachial plexus, these roots are actually the ventral rami of the spinal nerves. Okay, so there are a total of 5 roots, one from each spinal level. These roots combine to make trunks. The trunks recombine to make divisions. The divisions continue on and are called cords. And then the cords give off branches, which are called the terminal branches. And so the terminal branches are the named nerves of the upper limb. All right, so if you talk about, let's see, the radial nerve or the ulnar nerve, any of these nerves that are traveling through the upper limb are all branches of the brachial plexus. And so the first step in understanding this is to understand these divisions, all right, and the order: roots, trunks, divisions, cords, branches. And so there's a fun little mnemonic for that. Is the order of those is the same as this little sentence here: Randy Travis drinks cold beer. And so I don't know if any of you remember Randy Travis is the country music singer, but he definitely does drink cold beer, because here's a picture of his arrest when he was drunk in Oklahoma and naked in the street. So anyway, Randy Travis drinks cold beer helps us remember roots, trunks, divisions, cords, branches. All right, so now we're going to very diagrammatically name the parts of the brachial plexus. All right, so this is sort of an idealized diagram, okay, almost like a subway map version of the brachial plexus. And so I want to spend time doing it this way, so that way when you're in lab and confronted by the real anatomy, you'll have some sort of like a background, scaffold in your brain of what these things are supposed to be. All right, because yeah, like I said, when we see these in the real anatomy, they're not going to be spread out this nicely. There will be a little bit of variation in the pattern, so we want to understand the diagram first. All right, so let's go ahead and label each of these segments. So here are the roots. All right, so this is where the vertebral column is. All right, so the roots are coming out medially from the neck. Here are the trunks, divisions, cords, and branches. All right, let's go ahead and label our roots. All right, so here's the C5 nerve root, C6, C7, C8, and T1. All right, that's just a simple matter of counting. You should be able to observe those pretty easily. Now we're going to talk about how the roots turn into the trunks. Okay, the superior trunk is made from the C5 and C6 root. The middle trunk is made of C7 only, so C7 just travels straight across. And the inferior trunk is made out of C8 and T1. All right, next we're going to proceed to the divisions. Oh, sorry. I've put the chord names on here, but let's talk about how the trunks become the chords by traveling through the traveling through the divisions. All right. So the idea here is that some of the fibers from the middle chord are going to travel over here into the join with the fibers of the superior chord to make the lateral chord. Okay. So this lateral chord is receiving fibers from the superior trunk and the middle trunk. So that means the lateral chord has fibers of C5 through C7. All right. Meanwhile, the superior trunk is giving off a branch into the posterior chord. The posterior chord is also receiving some fibers from the middle trunk and the inferior trunk. All right. So at this point in the divisions, this is where we're getting sort of the most like mix-em-ups of the different nerve fibers. Okay. So this posterior chord is receiving fibers from all of the divisions. So everything from C5 through T1 is found in the posterior chord. The medial chord, as we see here, is effectively a continuation of the inferior trunk, and so it's only going to have C8 and T1. All right, I'll give you a moment to think about that. And I want to reiterate this concept here. All right, I mean, at this point, this may just sound like a lot of names and numbers for not much reason, but as we continue to follow these down the upper limb, we'll see a little bit of that today and more in future lectures. This will help you to understand how the dermatomes of the upper limb are organized. So if you know the medial cord is going to eventually become the ulnar nerve, you'll know that the ulnar nerve is going to have C8 and T1 fibers associated with it. All right. The posterior cord goes on to become the radial nerve, for example, and it's going to have fibers from all divisions within it. Okay. So this will help us to make sense of where we're going down the line. All right, now let's go ahead and start naming our terminal branches, okay? And the way I think about this is that each one of our cords has two major terminal branches. So the lateral cord has one major branch called the musculocutaneous nerve. This nerve will innervate the biceps brachii and the skin of the lateral part of the arm. The lateral cord is also going to contribute here into this structure called the median nerve. All right, median nerve. The medial cord is going to give off one major branch called the ulnar nerve, all right, which is going to go to the ulnar side of the forearm. And the medial cord also contributes to the median nerve. All right. The posterior cord, meanwhile, is going to branch into its two major divisions here, which will be the radial nerve, which travels to the radial side of the forearm, and the axillary nerve, which travels to the deltoid. All right, so we have three cords which create 5 main branches. All right, and the way I just sort of keep track of this is that each cord has 2 main branches. It's just that the median nerve is shared from 2 cords. One other quick note about terminology, be very careful with the terms medial and median. The median is a nerve, the medial is a cord. Now, let's go back and talk about the minor branches, all right? Each of our cords has about 3 minor branches, all right? So before we start talking about those, we're going to just talk about sort of the 2 exceptions, all right? We have here a dorsal scapular nerve, which we've seen previously in the rhomboids, and the long thoracic nerve, which goes to serratus anterior. Each of these branches off of the roots. All right, so like way up where the roots are coming out of the vertebrae is where the dorsal scapular nerve and long thoracic nerve arise. The superior trunk has 2 branches. One of these is the suprascapular nerve, which travels to the suprascapular muscle, or excuse me, supraspinatus muscle and infraspinatus muscle. And then we have this teeny tiny little nerve to subclavius, which only innervates one muscle, which doesn't do very much. And we'll be lucky if we're able to see any more about it. And so the other minor division of the lateral cord is the lateral pectoral nerve. The posterior cord has 3 minor divisions, which are pretty easy to name. They're all called subscapular nerves. Each of these subscapular nerves travels to the subscapularis muscle and its sort of related areas. And so these are just named as the upper, middle, and lower subscapular nerve based on their proximity to the vertebral column. The medial cord has 3 minor branches, each of which contains the name medial. And so they're abbreviated here, all right, MAC, MBC, and MPN. And so the M in each of those cases stands for medial. So all the medial nerves come from the medial cord. So that's nice. MPN is the medial pectoral nerve we saw previously. MBC is the medial brachial cutaneous nerve. And so that means this travels to the medial surface of the arm and is sensory innervation to that area. The MAC is the medial antebrachial cutaneous. And so that means it travels to the medial surface of the forearm and is sensory in that region. Okay, so that does it for our diagram. All right, definitely spend some time practicing that. All right, you're going to want to be able to, draw that diagram in your sleep. So once we, start looking at this in the real anatomical context, you'll be able to sort out what is there. All right, so here is a slightly more realistic view. So when you actually see this anatomically, you're not going to be able to see the whole extent. All right, as we dissect the axilla, we'll probably only see about this much. Being able to see the roots and divisions is not something we'll be able to really observe until we dissect the neck later on. All right, so for now, our dissection will focus mostly on the cords and the branches. And so the cords are all arranged around the axillary artery. So when you reflect the pectoralis minor muscle, you'll see that axillary artery. And that axillary artery is surrounded by those 3 nerve cords. And one sort of helpful thing here is the name of the cord describes its position relative to the axillary artery. So if you're lateral to the axillary artery, you're looking at the lateral cord. If you're medial to the axillary artery, you're looking at the medial cord. And if you are posterior to the axillary artery, you'll be seeing the posterior cord. So they're arranged around the artery, sort of evenly spaced around its surface. Notice here how the cords combine to form a couple of these named divisions, the musculocutaneous nerve, the ulnar nerve, and the median nerve. As we have 3 branches coming out of two chords, we get this very diagnostic M shape. All right, finding this letter M in your dissection is probably a good first step. This will really help you to get your bearings when you're trying to identify which of your nerve branches and nerve cords you're able to see. All right, so now we're going to move on to a couple of clinical correlations to the anatomy we've already described. So I'll try to, pause and ask questions as we go through this, but this is also a good opportunity to, look at this slide, look at these slides without the narration, and see if you can solve these problems. So breast cancer, all right, there are a couple of superficial signs, a couple of surface anatomy things that are visible that might be indicative of breast cancer. All right, so we'll talk about these physical signs here in just a second. But before we do that, let's talk about sort of the quadrants of the breast. I mean, basic anatomy here. You can divide the breast into quadrants by drawing this T shape through the nipple, and it will define quadrants simply based on their position. All right, so you have a superior medial quadrant, an inferior medial quadrant, inferior lateral, and superior lateral. Now this superior lateral quadrant actually travels pretty far up into the axilla, all right? So there is breast tissue and fat there that is sort of merged into the axilla. It's called the axillary tail of the breast. And so this superolateral quadrant is where most breast cancers arise. I don't know if there's anything specific about that region or if it's just because it is the largest of the regions. But basically, you'll want to note these percentages just as sort of breast cancer risk awareness metrics. The other thing to mention here is that, oh, right, the physical signs. So if you have a mass in the breast, these physical symptoms can be caused from a variety of things, but one thing is if that mass is present, it's going to put traction on the ligaments. All right, remember those suspensory ligaments of the breast? If those are retracted, if those have pressure put on them by a growing mass, it will cause dimpling in the skin. We also can get edema of the skin. Okay, so this is fluid retention because of lymphatic drainage. So if there is a mass blocking the lymphatic drainage, you can get this, it's called orange peel skin because it has this dimpling like the skin of an orange, and that can be a sign of lymphatic involvement. Abnormal contours are caused by just the physical presence of a growing mass. And then nipple retraction, this can also be a sign of breast cancer, but I just want to point out there's a lot of morphological variation, natural variation in nipple morphology. So some people have naturally retracted nipples and it's not a source of concern, but if there are changes in nipple morphology, that's more when you would want to make sure to get it checked. Okay, I think that's all about that. Okay. Brachial plexus injuries have a whole variety of symptoms, but based on the location of the injury, we can usually sort of assume what symptoms we're going to see, or vice versa, you can use the symptoms to diagnose the location of the injury. All right, and so one specific type of brachial plexus injury is injury to the superior brachial plexus, which is caused by, well, this terrible injury here falling on your neck, or during delivery. All right, and notice the similarity between these two injuries. All right, what has happened is that the neck has been pulled away from the thorax laterally, causing additional stretching of the structures in that cervicoaxillary canal. All right, and so as the brachial plexus passes through that cervicoaxillary canal, if it is overstretched by this forced lateral movement of the neck, it can damage this superior cord. All right, so if we're pulling the neck this way, you're going to put a lot of stretch on these upper divisions here. All right, and so when that happens, you are going to lose some of the innervation for the branches off of that superior trunk. And so the symptoms are as described here, all right? And all of the reasoning is described here. I'm going to let you try to work that out, all right? I think it would be valuable to sort of make sure you can piece together how these nerves travel and what their functional deficits will be. And we can talk about this more in review if there are specific questions. All right, and then I've also asked you to speculate about other injuries. All right, we don't see in this picture an ulnar or radial nerve palsy, but think about what injury could cause the ulnar nerve to be damaged. What symptoms will result? what injury could damage the radial nerve and what symptoms would result. All right. So another sort of activity you can try as you're studying. All right, the thoracic outlet is basically the same space as that cervical axillary canal. All right, it's sort of this whole area behind the clavicle that we've described earlier. And so lots and lots of things are passing through that space. If that space gets narrowed for any reason, if there's an impingement or a closure of that space, you can damage basically any part of the brachial plexus and or the artery there. All right, so a couple of common locations of impingement include the interscalene triangle. This is a space between the scalene muscles of the neck. We haven't talked about the scalenes in detail yet, but all the branches of the brachial plexus are traveling between the scalenes. And so if those two muscles are, squeezed together for whatever reason, I mean, even a tendinitis, these muscles can hypertrophy with certain respiratory problems. You can pinch the nerves of the brachial plexus. The space between the rib and the clavicle is called the costoclavicular space, and that's always a narrow space. And if that's impinged, same situation. And then the intrapectoral space, this is the space between the pec minor and the first rib. All right, this is where we looked at how the axillary nerve, or excuse me, axillary artery travels deep to the pectoralis minor muscle. And so if that space is impinged, again, by the muscle movement or whatever, you're going to get, again, the same set of symptoms. We talked about the long thoracic nerve previously, how it is very superficially located, how it's like right under the skin on the thoracic wall. And so if this nerve is injured, it only innervates one muscle, so you're only going to lose one muscle function, and that muscle is serratus anterior. And so what happens is that the scapula sticks out more than its counterpart, because when the serratus anterior sort of like at rest is holding the scapula close to the thoracic wall. All right. If you're not actively using the serratus anterior to like throw a punch or whatever, it's always sort of holding the scapula in position. And so if that nerve is injured, the scapula will stick out in a very obvious sign called the winged scapula. The long thoracic nerve originates from the roots C5 through C7, which gives us this little mnemonic here: C5, 6, and 7, wing your way to heaven. If you have an injury of those nerve roots, you will have the winged scapula. Pectoral nerve injury is not super common because those pectoral nerves are pretty well protected. So the pectoral nerve is not likely to be injured from like an accident, all right, like a specific injury to the shoulder, but more often from repetitive stress injury. At least one of these cases came from a person who I think was like a warehouse worker, like loading boxes. So raising the arms, lifting above the head all day long, uses the pectoral muscles. And with this repetitive stress kind of injury, it can actually impinge the pectoral nerve and cause atrophy of the pec muscles. And so the most visible external sign of this is asymmetrical nipples. All right, so here is where we would expect the normal nipple line. And you can see here how the right nipple has been raised up. All right, it's higher than it should be because that pectoral muscle has atrophied. And so the nipple has sort of, followed the muscle, right? As the muscle gets smaller, it gets closer to the chest wall and elevates. All right. So yeah, repetitive stress injury is common. All right, the other type of repetitive stress here is actually just getting punched in the shoulder a lot. Okay, so like I said, not super common from a single injury to the shoulder, but if you are using the arm a lot, or if you are getting hit in the arm a lot, you can eventually end up with pectoral nerve palsy and atrophy. All right, and we'll just close out with a summary. All right, so this just hits sort of the what I think are the most important points from this, and so make sure that you understand all of the basis of the structure of the summary described here, and you should be doing all right. Thanks for your attention.